So I've been saying that ultrasound is the workhorse of cardiac imaging, and so really 90%, if not more, of cardiac imaging that is being done is actually based on ultrasound. All the rest is much, much, much smaller. But one of the things that we said before is, so ultrasound also has some disadvantage. So, and especially as we say the transthoracic ultrasound, so where we have to go through the thorax in order to do the imaging. What we said is that you need to go in between the ribs, and so you might have quite a lot of artifacts. And you can also only do specific sector imaging with quite some limitations. So you cannot easily look at all sides of the heart. And especially looking at the valves in details or looking at the atria in very much detail is actually quite difficult. And another thing is also is that, of course, the farther away you are from what you want to image with ultrasound, first of all, you need to use a lower frequency. So because we said you have frequency dependent attenuation. So high frequencies cannot penetrate as deep as low frequencies. But low frequencies have much less resolution. So that means for the deeper structures, so especially like the further parts of the heart within the chest of an adult person, we need to use relatively low frequencies, and we don't have high resolution. Plus also the other thing that we said before is because of the fact that if we would go from one medium to the other, so if we go from solid to air to solid, we know that everything is reflected. Just like bones reflect everything, like a small layer of air between the transducer and the skin would also not let ultrasound penetrate. So we need to use these kind of ultrasound gels in order to do that. So all of these are some disadvantages. And so if we really need to look in more detail, and especially if we do some complex surgery, for example, where we want to do real-time monitoring, what we can do is we can use transoesophageal echocardiography. And so what we do there is we actually bring the probe, which is now at the end of an endoscope, we let the patient swallow it, and we go through the esophagus, and we can even put a transducer into the stomach to be able to do imaging from very close by. So the advantage is we can go closer, we can go at a higher frequency, thus a higher resolution. We don't have the problems of the ribs, of course, and we don't have the problems potentially of the layer of air in between. So in that sense, is we get much more detailed and much more high quality images. Of course, at the big disadvantage that you have to swallow this tube. And so whoever got a gastroscopy, for example, or a transoesophageal ultrasound, this is definitely not comfortable in order to do it. Plus also, the esophagus is actually, although looks like a simple organ, it's something that can cause a lot of trouble. Because if you get a rupture or some kind of cut inside your esophagus, there's huge problems. Because what you then get is you get the outside world, so from what's in your mouth, and so with a lot of bacteria and things like that, you get it directly inside your thorax. So esophageal lesions have a very, very high mortality and morbidity problem. So although it doesn't happen too often, there's always this risk that you do it. So because of this, of course, we like to limit transoesophageal ultrasound to, again, the times that we really need to get the details. And so these details are very often, if we want to look at the atria, we want to look at the valve, or we do interventions of the valves. And so what happens here is that what sometimes happens is that your valve is leaking because of the fact that your heart became so big that your valve is actually being stretched so that the leaflets are not touching each other anymore. And so that means that while wanting to close, they cannot fully close. And so get problems with what we said, this volume overload and the regurgitation. So here you can nicely see this in a color Doppler image. So where you see that blood is going towards the atrium from the ventricle. That shouldn't happen. This valve is not closing properly. And so currently one of the therapies that we can do is we can use this kind of clipping. So where we actually take, so we go in with a catheter, and then we try to, with a small gripper, we try to grasp the two leaflets and then put a clip on it. And so this way we try to keep the valves from being closer together, and thus try to solve part of this problem. And of course, since this is quite complex to do this from the outside, so you need to put a catheter, you need to find ways to grasp this kind of things and so on. So it's quite a complex intervention. And we do this under continuous monitoring of echocardiography, together actually with, of course, X-ray imaging. Because X-ray imaging, we need to know where we are putting the transducers. Ultrasound, we use at the same time. And actually, this is one of the few applications where we also use 3D ultrasound in clinical practice in order to kind of guide the catheter to see that it's exactly in the middle, exactly at the right place. And then, of course, look at whether we improve the regurgitant flow. So the last thing of ultrasound is that actually what we can do is we can put the catheter, we can put the transducer on top of a very thin catheter. So we can even make such a small transducer that we can actually image from inside the vessels. And so what we do is we can make a cross-section of the vessel. And here you nicely see how this is useful, because when we do angiography, what we do is we fill the vessel with contrast. And so while filling it with contrast, we can see where it's narrow, but we cannot see why it's narrow. We cannot see how much already of this vessel is dilated and how thick actually the plaque inside is, or what composition it has. And so by doing ultrasound, we can actually make cross sections, and you can nicely see here. So in this one, you see this is the open lumen, but here you see that the vessel is much bigger and that there's a lot of plaque being accumulated. And you see also some which actually attenuates a lot, some attenuates less. So you can try to look at fibrous versus fatty type of plaques. While this provides a lot of information, it has two big disadvantages. First of all, you use a catheter, and in patient applications, catheters are in principle for single use because of problems with kind of sterilization, potential infection, potential failure. Most of the catheters that we use is for single use. A catheter like this is almost €1,000. So this would add €1,000 to every examination, which of course is not feasible. We cannot pay this. Plus also the information that it gives, although it provides more information clinically, because you see what's going on in this vessel, it doesn't hugely change the clinical decision making. Because still, we would mostly only treat the vessel with stents when it's clearly visible on the angiography. Because it doesn't help the patient on the long term if we do it earlier. So that makes that this is like, although a very nice imaging modality to look at details, it's something that's only used when we do like pathophysiology research, and we really need to know these details in order to understand something for a new drug or a new type of stents or something like that. Okay. So as last imaging modality, we obviously have MRI imaging. And with MRI imaging, because we can look at soft tissue so well, we can make really nice images of the heart. So you can really see the full anatomy. You can see the full anatomy in 3D, which is a big advantage. But the disadvantage is, of course, that, as we know, it's at a relatively low spatial resolution, and also the temporal resolution is also less. We can do dynamic imaging, so we can really look at the contraction of the heart, but keep in mind that this is most often being done over different cardiac cycles. So we can only do this in patients that have a very stable cardiac cycle. And then, of course, also only at a temporal resolution, which is in the order of the variability of the heart rate. So because we cannot time it better. But still, this is quite useful to look at some motion. With a big disadvantage compared to echocardiography is that we really have full resolution 3D or 4D images if we take the time as a 4th dimension. So here you see an example of what I was telling, these very big hearts. So this is one of these hypertrophic hearts with these genetic abnormalities, which would lead to fiber disarray. So we see that this is an extremely thick heart. And you see that the cavity here is very, very small. And one of the things that you also see additionally is what you see here when you look at this image. So you see these kind of black spots appearing around here. So we know that MRI imaging is where we have to, the dynamics of, we first like locally flip the angles of the protons, and then we look at the dynamic recovery of these. So what happens is if we have very, very high blood velocities, then obviously the spins that we had flipped, they move out immediately. Yeah? And so that's what you see. So you start to see this kind of blackening here because you have extremely high velocities here. And that's actually because at one side here, a leakage of the valve, and the other side, what I was saying before, is the wall becomes so thick that it actually becomes an obstruction towards the outflow. So you really get flow acceleration there because you start to get a stenosis, now not because of a problem with the valve, but really because of a so thick wall that it actually starts to obliterate the cavity inside. Here's an example of an infarct patient. So what you now see is you see here that around the apical wall, you see that the wall becomes very thin and is actually not contracting at all. And what you now also see is that you start to see this kind of wiggling of the heart inside the sac. So you see here, the outside boundary is not changing. And you actually also see that there's this white is actually liquid around the heart, between the heart and the pericardial sac. And here there's a little more liquid than normal. Normally you have this liquid because what I told you before is you have the sac around the heart and the heart can freely move there. So of course this needs to be frictionless. So you have a very little bit of fluid in a normal heart there. But if you start to get this like big abnormalities, you start to see that there's an accumulation of fluid. And if you have really a lot of fluid, it actually also becomes problematic. You see here nicely how this kind of apex is wiggling within this heart in between this fluid. This is an example of a patient with this kind of very dilated, so you see a very big heart, and you see here this hypertrabeculation. Although the resolution is not good enough to see the trabeculations in detail, you see the sponginess around this apex, and actually you see that this actually becomes very, very abnormal. And the other thing that you also see now is what I was telling you, is this heart became so big that actually the valve plane here, so this is what we call the annulus, the opening of the valve, has been stretched and has been stretched in such a way that you start to see also, and also what you see is that actually these cords here, because the heart has grown so much, the cords are also being stretched, and you see that this valve cannot close. You see this valve stays like this tent, like as we say, and you see there's a big leakage. So a lot of blood, while it contracts, it should actually only go into the aorta. You see now actually quite some blood going back from the ventricle into the atrium because of this leaking valve. So these things you can evaluate also quite nicely with MRI images. You can do at a higher temporal resolution with Doppler, as I said before, but you can also use MRI for this. What currently MRI is used for quite a lot in cardiology is actually to try to detect scar, to try to detect infarcts. What they actually noticed is at some point is when you use contrast agents in MRI, so you use gadolinium-based contrast agents. So when you inject the contrast agent, of course, that contrast agent first comes into the blood. And you can actually visualize this. So you can really see an opacification of the blood with a contrast agent. But what I also noticed is if you leave the contrast agent and you start looking at, for example, 10, 15, 20 minutes after injection of the contrast agent, what happens is that these large gadolinium molecules are actually starting to get trapped in scar tissue. And so you see, so this is actually animal experiments with infarcts of bigger size. So you start to see that the contrast agent is really accumulating and highlighting the real infarct. And one of the things that you see now is also the dynamic of infarct creation, because if you think back of what I was saying about the anatomy, so the coronary arteries are at the outside of the heart, at the outside boundary, and then the vessels grow towards the inside. So that means actually that when we look at the tissue, the more inside the tissue is, more vulnerable it will be when there's a problem with the perfusion. The outside part always gets blood because that's where the big arteries are. But the inside is the thing which is first getting into trouble. And so when we have an infarct, what we see is that if you have an infarct and you get a stent quickly enough, you see that it's only a little bit of the inner layer that becomes infarcted and becomes scar. If it's a bit longer, you see that it can become half, so it grows. And if it's really long, you see that it's what we call like a transmural infarct. That means that the whole wall is actually gone. And so it is what we call delayed enhancement MRI, so where we inject contrast agent. And then after a certain amount of time, we're going to check where this contrast agent went to. We can actually really image where infarcts are. Now, as I told you, one of the problems with MRI is that in order to do fast imaging, and especially keep in mind, cardiac patients, the one that you're mostly interested in, they very often have a heart which is problematic. And one of the things that you will see is that if they lie down, so the really one with worst heart failure, if they lie down long on their back, what actually happens is that the lungs will fill with water. So these patients cannot lie still on their back for a long time in an MRI. So that means that you need to do fast imaging. That means that also you have, of course, much less contrast and resolution. So in order to get really good images with MRI, we need to image long. Just to show you what you can get, and this is actually a detailed heart. This is now ex vivo, but this is imaged during 24 hours imaging in the MRI. And you see really that you can look at all the details of trabeculations and so also in MRI imaging. But while, for example, in a synchrotron, you image for 5 minutes, and in MRI, you need to image for 24 hours in order to get these types of resolutions. But it is possible, but of course not in clinical practice. Here's an example also of a kidney which is scanned with very, very high resolution, but then again over 24 hours. Now, if we do that, if we image long enough, we can really see, for example, these trabeculations. So this is like a video in a beating heart. So this is experimental. This we cannot do in clinical practice because you need to replace the blood. So that's not that easy. That needs to be on bypass, for example. But what you see here, these are actually images from the Visible Heart Laboratory. And what they have been doing is they have been collecting hearts from patients that died or hearts that have been explanted. And then they've put them in a block of gelatin and then put them in the MRI for a very long time. And then you really can analyze the really morphological structures and how this is changing and how this can change with disease, of course, also. As I told you before, in principle, especially after contrast, you can also look at coronary arteries, but in reality, the MRI resolution is not good enough to do that. So while experimentally some people have been looking at coronary angiography with MRI, actually in clinical practice, it's not being used. The angiography, X-ray angiography, is still the gold standard. And as I said before, CT is taking over some of it. If we can look at the proximal part only, and if we have a low pretest probability of finding something, so we have to immediately go to treatment. But MRI in principle is not used much for it.
One question, Bart.
Yes, go ahead.
In the previous slide that you were mentioning, the block of gelatin, is it related with attenuation or is it just clinical
No, this is just, you put it in a block in order to fix it. So to fix it and to put it in a block, because these are hearts that are taken out and you have to put it on the table of the MRI. So it's not so easy if you would have this heart. And also the other thing is what you want to do is you want to preserve the shape as much as possible. So that means that you have to fix it under a certain pressure, because otherwise, of course, the right ventricle would collapse.
Okay.
So this is a way to do ex vivo imaging in a reasonably native state. That's why you put it in gelatin or paraffin, something like that.
Okay, thank you.
Okay, another way that we also said is when we look at MRI images is that with MRI, we can actually also measure velocities. So by doing phase contrast MRI in this case, or doing perfusion diffusion imaging, we can really look at blood flows. And that is actually quite relevant in cardiology, or in cardiovascular applications. For example, when we look at blood vessels, this is actually a simulated flow, but looking at flow within vessels or within aneurysms or within aortas with enlargements, that's actually something which is very, very relevant. And so we can either do MRI imaging and then measure Doppler-like signals, so we can do velocities as a function of time, with what I said before, much less temporal resolution than Doppler, but much better spatial resolution and localization than Doppler. So you have advantages, disadvantages. But what we actually can do is we can really measure the 4D vector of the flow. With Doppler, you can only measure the flow in the direction of the probe. We cannot, with Doppler, directly measure the other components. And of course, velocity vectors have 3D, so they have 3 components. Here is an example of measured with MRI, the flow within the aorta, and you can nicely see here how it spirals. So this is actually a kind of exaggerated spiraling in an aorta which is dilated. So this is actually a patient with an abnormal aortic valve, but even in a normal aorta, you have spiral flow. And this is again an example, which is like, to me, a typical example of how nature evolves always towards trying to preserve energy. Because imagine you have the heart contracts and it pushes blood into the aorta. So what you need to do with contraction is you accelerate blood, then the valve closes and the heart is relaxing. So that means that you have to stop the blood for a while. And then with the next heartbeat, you again put the blood forward. Now, you know from Newton's law that acceleration and deceleration of an object, that's the thing that uses energy. Having something move with the same speed, with the same velocity, doesn't cost any energy. Of course, if you would lose energy with heat generation or friction or whatever, you have to compensate for this. But having something, keep it moving is much more efficient. So this is how now the heart evolved. It evolved that when you contract, the blood is being pushed into the aorta. And then instead of stopping, what actually happens is that the blood changes direction and starts to locally wire around. So the only thing that happens is that actually the direction of the velocity vector is changing and the velocity amplitude is not changing. And changing the direction instead of the amplitude is much less energy consuming. And so you see that you get this kind of resulting in a spiral flow in the aorta, which you can prove that that's energetically the best way. And so by studying this and how this changes with different pathologies, you can try to understand better some of the remodeling and potentially even infer some inefficiencies in the heart. And here's an example of then doing the full analysis of the flow through the heart. So you nicely see how flow comes in, then whiles around, spirals around, and then goes out. And so you could even measure, this is like a colorization of how long a blood particle stays within the heart. So whether it is already ejected in the same heartbeat or in 2 or 3 heartbeats later, which is particularly important because in some of these very dilated hearts, what you get is that if blood stays too long without moving, it can start clotting. And so this way you can really analyze these things. So this is an example of how 3D velocity imaging over time can help in order to look at more details. And then lastly, what you could do is also, I told you that you can do diffusion tensor imaging with MRI. And I showed the example where you can look at the fibers in the brain in high resolution. Theoretically, you can do that also for the cardiac fibers. But unfortunately, the resolution of the MRI, especially with the beating heart, is definitely not good enough. And we see much more with synchrotron imaging for fibers currently. Okay. Any questions about this? Okay, so that means that now we finished with the classes. So you still have the practical and seminars going on. And also, as I told you before, for the exam, yes, please.
How do you think in the future these synchrotron images can be approached to the clinical environment?
Yeah. So the advantage of the synchrotron is that you can do phase contrast imaging. And you can do that by the fact that the photons that you're using are much more coherent. So they're much more, it's more cleaner X-rays. If we are able to do that in a CT scanner, there's actually no reason why we could not use this type of approaches in the CT. We might not be able to go to the lowest resolutions, but at least we can improve the contrast a lot. And there's actually two ways forwards. Is one that we create mini synchrotrons, and there are some kind of developments going on there, where you use, instead of just an electron beam which goes around in a large magnetic ring, where you use actually a linear electron beam, and if you shine an extremely bright laser on that electron beam, you can actually also generate X-rays. And that would be like, currently they can make these, you can call it tabletop or room synchrotrons. They can make these for about 3 to 4 million euro. You can say this is still a lot of money, but keep in mind, when we have a cyclotron, which is needed for a PET, to make radioactive pieces for a PET, a cyclotron also costs like €1 million. And some hospitals have a cyclotron inside. So it's not totally unthinkable that in the future, the price of this comes down enough that this is in the range that is kind of affordable by hospitals if it provides new information. And the other way is actually that people are also investigating, and that is actually already coming into commercial systems, for example, for breast imaging, where you actually use very, very narrow slits. And by putting slits in different angles in between the X-rays, you can actually also clean up X-rays. So there's different ways to actually do this type of phase contrast imaging in regular CT scanners, or more or less regular CT scanners. So hopefully in this and 10 years or something like that, this is something that could work in clinical practice. So where we can really improve CT imaging a lot. And actually, since it's much easier to do CT imaging compared to MRI imaging, a lot of that imaging could be taken over. Of course, there's still always the problem with the radiation. X-rays are ionizing. But if we go to phase contrast imaging, we can go to much higher energies, much less absorption, and so much less biological damage. So in that sense, it's like I'm expecting that in the next decades, there will be a big evolution in CT by having this incorporated.
Bart, I had another question for you regarding magnetic resonance imaging.
Mm-hmm.
And it was, well, we saw that it had this image modality had a lot of advantages, but one of the biggest disadvantage was that it only allowed the visualization of hydrogen, no calcium. So the disadvantage was that we weren't able to see bone. And my question was, this image modality seems quite nice because it has, as we saw, the great tissue contrast and so on. But in my opinion, I think that not seeing bone is quite a concern, quite a problem when looking, for example, at the structures like the brain. So my question was if there is like an alternative way apart from combining image modalities in future regarding trying to get the visualization of bone when talking about magnetic resonance, or is it impossible to get the visualization of calcium?
Well, it's not impossible, because magnetic resonance, by definition, every kind of magnetic structure and also even protons within different atoms would have different resonance frequencies in some ways. And so theoretically, you could devise magnetic resonance scanners which would predominantly look at other atoms than just like at hydrogen atoms. And actually, there is some research being done, and there's some applications, but not really clinical, for phosphor imaging, for example. And phosphor is actually also a part of bone, or an atom which is present a lot in bone, and so could be used for this. But in the end, all of this would mean that you have to make dedicated scanners. So really, your coils and your gradients and everything, they have to be adapted. And then to have a bone scanner, which is actually so expensive to develop and make and install, it's not worth the effort up to now. So I don't think there's an immediate way forward to, in the same machine with the same hardware, to do all the imaging. So, and since having bone imaging with regular follow-up and in younger patient, it happens so infrequent that actually people use CT scanners for it. And I don't think that will change very soon.
Okay.
So.
And well, a final nuance, and I will stop. It is like a silly question, but I think, or I was wondering whether there is a kind of fight between clinicians because for example, if a patient has a metal prosthesis in his hip, maybe it is like a kind of restriction to use image modalities such as this magnetic resonance because we can't take them into the scanner place, scanner. So my question was if there is like a kind of fight between the clinicians performing this kind of imaging and the ones that are introducing this kind of hip prosthesis, because it is like if you have 40 years, if you are 40 years old and you have suffered an impact in your hip or an injury or something like that, maybe the fact that you are getting a metal, like a chronic metal prosthesis, it is like a restriction for you in the future to obtain better imaging in a situation that may be worse than this kind of injury in when you are 40. So my question was this.
Yes, exactly. The thing is, indeed, this is a potential problem. But what you see now is that in the medical community, I think everybody agrees that prostheses have to be MRI compatible. It's actually even in such a way that the FDA, so the approval organization, is asking for computational modeling of heat generation of implants when you put them in an MRI scanner. So this is actually part of the evaluation of new devices and things like that, because they do realize that it might need to be possible, it might be needed in the future to be able to do an MRI there. So you will see that all the new devices for the last quite a couple of years are in principle MRI compatible. So that means that at least you can do some imaging. Similarly, for example, pacemakers or electronic equipment. So again, there it has to be. What you still see is that the people doing the imaging, so the radiologists, they're still very, very hesitant in order to do it. So as a clinician, you really have to be convincing and say like, look, I need to scan. This scan is the only way I can get this information. And only then they will do even with MRI compatible devices, especially when it's electronic devices. So it's always still a tension, but all of the ones are actually regulated. So this is really a concern that has been recognized indeed by the regulators. So.
Okay, thank you very much.
Okay. Any other questions? So otherwise, I will very briefly again repeat with regard to the exam. I will, in the next week, send you out a scheme with the timing of everybody. So if you have one of the 2 days that is foreseen, you have another exam, then send me an email. Then I try to put you on the other day. So based on this, you will have a slot of about 20 minutes where we will discuss your exam. And the idea is that I send you on the Friday before. So Monday and Tuesday is your exam, but on the Friday before, I will give you about 4 hours to answer some questions. So I will send you the questions. Everybody gets the same question. You answer them. I will tell you how to do it. It will be very short. You don't have to write a lot. You can do short answers. I will ask you, for example, to find some type of images and then comment on them. You put that in. You will have to make a task in Aula Global that you can submit it. And then on the Monday, Tuesday, we will discuss this. You will tell me why you answered the questions like this. And then I will ask you questions. For example, it might be that you discuss or you say that nuclear medicine can solve some problems. It might be that I then ask you, okay, explain me how this works. So explain me some of the principles and things like that. So in principle, you can use whatever material you want. I don't think it's ideal to collaborate a lot, but I leave everything up to you. But the main thing is that you are able, when I ask you questions, to explain me why you gave a certain answer, and then explain me how the imaging modalities are working. And that's the most important for me, is you need to know when I show you an image or when you have an image, Why are parts black? Why are parts white? You don't need to be a radiologist. I don't want any diagnosis. You don't need to put anatomy in detail. If you can, the better, but that's not going to make the difference. But what you have to tell me is why, for example, some parts are black while some parts are white within the images. And then reason about this with regard to how these modalities work. To me, that's the most important. Okay. Any other questions? Otherwise, thank you very much and have a nice evening.